Hello friends, we will be discussing about the drugs acting on hemostatic mechanisms. They can be either coagulants and anticoagulants. The objective of this session will be at the end of the session, you should be able to know how blood clots are formed. You should be able to discuss the drugs which can be used for regulation of blood clotting. You also should be knowing various clotting deficiencies and measures to rectify those deficiencies. And in the next session, we will be discussing about which drugs can be considered as anticoagulants. So, we have seen that the blood clots with the vessel wall injury and activation of platelets. Now, classes of drugs which we will be discussing in this session will be drugs which can prevent bleeding and hemorrhage. They are hemostatics or coagulants. Drugs which can prevent coagulation means anticoagulants that we will be discussing in the next session. Drugs which can be used to overcome certain deficiencies as replacement therapies which can be used to rectify deficiencies. And there is another class of drug which is known as fibrinolytics or thrombolytics that we will be considering in the separate session. Now let us know something about, we have seen the coagulation cascade. Let us know something about hemostasis. You might have learned in pathology that hemostasis means arrest of blood. In short, blood coagulation. It is the interaction between injured vessel wall plus platelets and coagulation factors. Normally when the vessel wall is intact, there should not be any intravascular coagulation. But coagulation normally starts when the vessel wall gets injured. Now, how blood clotting that we have seen in the video. In nutshell, we can say that blood clotting takes place into three phases. One is vascular phase, followed by platelet phase and coagulation phase. Once the blood clot is formed in the vessel wall is sealed, that clot has to be dissolved. That is the fourth phase, that is fibrinolytic phase. Now let us consider first about the three phases. Vascular phase. As soon as there is any kind of injury, vasoconstriction occurs as a matter of, you can say the nature takes care that vasoconstriction occurs because of the exposure to tissues that activate tissue factor to initiate coagulation. Blood vessels constricts to prevent further blood loss. In the platelet phase, normally in the blood vessel wall, endothelial cells, they prevent platelet addition and aggregation. And platelets contain receptor for fibrinogen and von Willebrand factor. But this normally in the intact phase, they do not activate. In case of vessel wall injury or any injury, platelets change in their configuration. They tend to adhere at the site of insult and they aggregate. Also, they release permeability increasing factors like vascular permeability factor. And they lose their membrane and form a viscous plug. In the coagulation phase, there are two pathways, intrinsic pathway and extrinsic pathway. Both converge at a common point. There are 13 soluble factors which are involved in blood clotting. Biosynthesis of these factors are dependent on vitamin K1 and K2 that is synthesized by intestinal flora. Normally, they are in the inactive state. They do not allow internal clotting, and once the injury occurs, sequentially they get activated. Hereditary lack of clotting factors lead to hemophilia. As I have said, there are 13 clotting factors, 1 to 13. It's very difficult to remember all the clotting factors, but important clotting factors are prothrombin, proconvertin, Christmas factor, Stewart factor, and main important is to start with is Higman factor, but it's very difficult to remember the names of all 13 factors. So thank you very much for the person who has created this mnemonics. Now, as we have seen, the proteolytic reaction starts with the activation of Higman factor. Higman factor is factor 12. There are two systems, intrinsic and extrinsic system. The net effect of this uh, coagulation cascade is polymerization of fibrinogen into fibrin strands. Blood cells get trapped into the fibrin strands and they produce clot. These are the two systems. With the activation of factor 12 that is activated by some injury, with the help of high molecular weighted kininogen, it activates factor 11. A stands for activated factor. Factor 11 in turn activates factor 9. Factor 9 with the help of factor 8 and plasma phospholipids and in presence of calcium. Calcium is required for the activation of all factors. Factor 10 will be activated. Here with the extrinsic pathway also, with the activation of factor 7, there will be activation of factor 10, and factor 10 now, as we have seen in video, will activate prothrombin into thrombin with the help of calcium and plasma platelet phospholipids. This activated thrombin will convert fibrinogen into soluble strands of fibrin. Then with the help of factor 13 and in presence of thrombin, fibrin will be converted into insoluble form and that will form a meshwork. Now there are certain natural mechanisms which favor clotting, which also oppose clotting. Factors which favor clotting are fibrinogen, thrombin and platelets. Factors which oppose clotting are antithrombin, protein C, protein S, antithromboplastin and fibrinolysin. Now let us talk about the coagulants first. Coagulants are the substances which promote coagulation and they are indicated in acute hemorrhagic states. Normally, whenever there is any kind of tissue injury, our blood gets clotted in some minutes. But if a patient is on some antiplatelet drugs or if patient is having some congenital anomaly like hemophilia, there will be more blood loss which will be harmful for the life. In that period, in that condition, we have to treat the patient with coagulant plus as a supportive measure, fresh whole blood or plasma has to be replaced. Classification of drugs which can be considered as coagulants can be obviously natural vitamin K, K1 that is fat soluble vitamin that is also available in the market, that is phytonadione. K3 synthetic products, fat soluble menadione, acetonephthone, water soluble compounds menadione sodium bisulfate, menadione sodium diphosphate. Others can be human fibrinogen, antihemophilic factor, desmopressin, etc. Especially rutin and ethamsalate, they are used in gynecological practice. Now let us talk about vitamin K first. Vitamin K is fat-soluble dietary element which is required for the synthesis of clotting factors. We have seen in the coagulation cascade, some of the factors are synthesized in liver with the help of vitamin K. The dietary sources of vitamin K is green leafy vegetables, cheese, liver and dairy products. Daily requirement of vitamin K is uncertain because K2 is produced by colonic bacteria. Just 3 to 10 microgram per day is sufficient for an adult person. Total adult requirement is 50 to 100 microgram per day. The action of vitamin K is it acts as a cofactor at a later stage in the synthesis by the liver of coagulation proteins, prothrombin, factor 7, 9 and 10. Vitamin K activates these factors by increasing their capacity to bind with calcium and to get bound to the phospholipid surfaces, which is essential to get involved in the coagulation cascade. Now, deficiency of vitamin K is known as hemophilia. Also, that is the congenital anomaly, but also it may be seen in prolonged liver diseases like obstructive jaundice, malabsorption syndrome, prolonged antimicrobial therapy, which alters microbial flora, so no formation of K2. The manifestation of patient having vitamin K deficiency is more bleeding tendency. Clinical signs may be hematuria, bleeding from GIT, nose and under the skin, ecchymosis patches may be seen. How to treat? Vitamin K can be useful for prophylaxis and therapeutic therapy of bleeding due to deficiency of clotting factors in the following situations. If a patient is on prolonged AMA therapy, antimicrobial therapy, 5 to 10 microgram per day oral or parenteral vitamin K can be given. Dietary deficiency if patient is having malabsorption, which is rarely seen in adults. Thus, if it is there, then 5 to 10 microgram of vitamin K per day can be given either orally or parenterally. If a patient is having obstructive jaundice, malabsorption syndrome like regional ileitis, steatorrhea, etc., vitamin K 10 milligram intramuscularly can be given once a day, either intramuscularly or orally. But mind well, bile salts are necessary for their absorption. Bile salts are required for the absorption in case of if patient is having malabsorption and obstructive jaundice. In the newborns, especially premature newborns, to prevent blood loss, vitamin K 1 milligram intramuscularly should be given soon after birth or 5 to 10 milligram intramuscularly to the mother 4 to 12 hours prior to premature delivery. If it is to be planned, it's a planned delivery and the baby is premature, we have to give 5 to 10 milligram intramuscularly to the mother. This will prevent or treat any hemorrhagic diseases in the newborn. This is very important use of vitamin K. Overdose of anticoagulants, especially warfarin, that is oral anticoagulant. If it is given in larger dose, the antidote of warfarin is vitamin K. Usually vitamin K1 phytonadione is given, that is the drug of choice. In case of severe overdose, 10 milligram intramuscularly is given stat followed by 5 milligram 4 hourly till bleeding stops. Usually the bleeding will stop within 6 to 12 hours. If there is moderate overdose, 10 milligram intramuscularly stat followed by 5 milligram once or twice. In case of mild overdose of anticoagulants, just omit few doses of warfarin or anticoagulant. If a patient is on prolonged high dose of aspirin, that will lead to hypoprothrombinemia. Vitamin K prophylaxis prophylactically can be given, or if bleeding occurs, 10 milligram intramuscularly stat followed by 5 milligram once or twice. What happens if vitamin K itself is given in large dose? The toxicity of vitamin K also is very harmful. Rapid IV injection of emulsified vitamin K can cause flushing, breathlessness, tightness in chest, fall in blood pressure, and death may be due to respiratory failure or it may be due to emulsified product. Minadione and other water-soluble derivatives can lead to hemolysis, especially in G6PD deficient patients and neonates. That may be reflected as kernicterus in the newborn. Ethamsalate is the drug which is used in the gynecological practice that comes under this class as coagulant. It reduces capillary bleeding by having anti-hyaluronidase property that improves capillary wall stability. The use of ethamsalate in routine is for the prophylaxis and treatment of menorrhagia after abortion, in case of PPH, epistaxis, after tooth extraction, etc. The adverse effects of ethamsalate will lead to nausea, rashes, headache, fall in blood pressure, especially if it is given by IV injection. Usually, it is given by oral, or if it is severe PPH or severe menorrhagia, it can be given by IV in the dose of 250 to 500 milligram. In nutshell, take-home message after this session will be, at the end of this session, you should be able to know, or you should be able to have clear idea about the coagulation cascade, some important factors which are playing role in coagulation, and natural and pharmacological coagulants and their role. That's all about coagulants. See you later. We will talk about anticoagulants in the next class. Thank you.